My name is Dr. Vivek Srivastava. I'm one of the clinical coordinators at the National Confidential Inquiry into Patient Outcomes and Death, NCEPOD.
Hi, my name is McPherson. I'm an interventional radiologist from Leeds and was one of the co-authors of this study.
Despite advances in prevention, diagnosis, and treatment of acute pulmonary embolism, it still remains a significant cause of morbidity and mortality across the world. In fact, a 2005 report from the House of Commons Health Select Committee estimated that there were more than 25,000 hospital deaths across the NHS in the UK. Previous studies have also shown that for every patient that is diagnosed with acute pulmonary embolism, there are another 2.5 cases of undiagnosed fatal pulmonary embolism, which puts into perspective the need for such a study.
A multidisciplinary study advisory group was convened to steer the study from design to completion. The study looked at patients who were coded as having a new diagnosis of pulmonary embolism. Both inpatients and those on an ambulatory care pathway were included. The standard NCEPOD approach to case identification was followed. Patients aged 16 and older were identified by ICD-10 codes for pulmonary embolism over a 2-month period in 2017. Case selection was biased towards those suitable for ambulatory care and also to those with severe pulmonary embolism. These were the areas where the study advisory group considered there was the greatest opportunity to improve care. Individual hospitals were asked to contribute a maximum of 6 patients. The restriction of 6 was to avoid overburdening or overrepresenting individual institutions or clinicians. The 6 patients were divided into 2 from each of 3 categories. A primary coding of pulmonary embolism with a length of stay of 3 days or less, any coding of pulmonary embolism with a stay of more than 3 days, or a primary coding of pulmonary embolism who required level 3 care or who sadly died. Within the population included in the study, 41.1% were less than 65 years of age. 20% had a prior history of venous thromboembolism, and a quarter of patients had active cancer. 56% of patients had a Rockwood Frailty score of 1 to 3. This means that the majority of patients diagnosed with a pulmonary embolism had no or minimal functional impairment prior to their presentation. In line with the existing NICE guidance and quality standards, the first principal recommendation of this study was that focus is required to ensure that an interim dose of anticoagulation, unless contraindicated, is given to patients suspected of having an acute pulmonary embolism, where it is anticipated that the confirmation of that diagnosis will take more than 1 hour. The study found that 18.7% of patients had an avoidable delay in commencing their treatment. In 54% of these patients, this was because an anticoagulant was not prescribed and/or not administered.
One of our principal recommendations was to document the severity of acute pulmonary embolism immediately after confirmation of diagnosis. We recommend that one of the validated severity scoring tools like PESI, P-E-S-I, were used for this process. This score could then be used to consider whether a patient required inpatient treatment or could be discharged to an ambulatory care pathway. Case reviewers found no evidence of formal assessment of severity of pulmonary embolism in 90% of cases, which was 436 out of 483. Similarly, data from clinicians' questionnaire, this was filled by the treating clinician, revealed that pulmonary embolism severity was not recorded in 81.6% of patients. Another principal recommendation was to assess patients suspected to having an acute pulmonary embolism for their suitability down an ambulatory care pathway, and to document the rationale for selecting or excluding such patients. 16% of patients who presented to hospital with a clinical suspicion of pulmonary embolism were cared for in an ambulatory care pathway for either part or whole of their journey. However, retrospective calculation of pulmonary embolism severity using a PESI score found that 194 patients would fall into the category of low risk, which is class 1 or class 2. 133 would fall into the intermediate risk group, that is class 3, and 162 would be high risk, which is class 4 or class 5. Looking into these groups further, we found that only 43 patients, which is 22.9%, were low-risk patients that were treated on the ambulatory care pathway, therefore missing out on a large chunk of patients that remain in hospital but did not require in-hospital care. Similarly, 11% of patients with intermediate risk and 8% of patients with high risk were managed on an ambulatory pathway, putting these patients at an excessive risk when they should have been admitted to hospital for their acute management.
One additional recommendation to highlight is one which may reduce the pressure on inpatient beds. It is recommended that hospitals ensure that an ambulatory care pathway is available 7 days a week at all hospitals where patients with an acute pulmonary embolism present. 83.1% of hospitals had an ambulatory care centre, but this was only open 7 days a week in 51.6% of cases. 16.9% of hospitals recognised that a lack of capacity in ambulatory care sometimes resulted in patients being admitted for a pulmonary embolism when they could have been cared for on an ambulatory care pathway. The case reviewers identified 11.7% of patients who were admitted for a pulmonary embolism who could have been cared for on an ambulatory care pathway. We recommend that the reporting of CT pulmonary angiograms should be standardised. A proforma should be used to ensure reliable reporting of the presence or absence of right ventricular dilatation. Computed tomography pulmonary angiography is the pillar stone of pulmonary embolism diagnosis. It also aids the assessment of pulmonary embolism severity, particularly if it results in right ventricular dilatation. Right ventricular dilatation causes valvular and left ventricular dysfunction and cardiac ischemia. 9.5% of the CT pulmonary angiogram reports were rated as poor by the expert case reviewers. In 90% of these, this was because there was no comment on the right ventricle. No comment on the right ventricle was also the cause of 55% of reports being rated as adequate. Overall, 37.5% of CT pulmonary angiogram reports made no comment on the right ventricle. It cannot be assumed that the right ventricle is normal if no comment is made. In 50.7%, there was no quantification of the size of pulmonary embolism. Proformas or other structured reporting systems for their CPTA reports were used in just 14% of hospitals. It is recommended that those assessing patients with a new diagnosis of pulmonary embolism should look for indicators of massive or submassive pulmonary embolism in addition to calculating the severity of acute pulmonary embolism. Those additional indicators should be hemodynamic instability, right heart strain, or elevation of troponin or brain natriuretic peptide. Abnormalities of any of these three categories should lead to the prompt escalation of care based on local guidelines. Patients with hemodynamic compromise are categorized as having massive or high-risk pulmonary embolism and should be considered for thrombolysis. The optimal management of those with submassive or intermediate risk pulmonary embolism is less clear. They should undergo enhanced care and may benefit from thrombolysis.
16.1% of hospitals had no guideline or protocol for the management of massive pulmonary embolism. For submassive pulmonary embolism, that figure was lower still, with 36.9% having no guideline or protocol.
Looking at the specifics of care, 29.4% of patients had one or more initial investigation omitted, which might have altered their place of care or treatment. The most commonly omitted tests were those used to risk stratify patients with pulmonary embolism. 32.4% had no arterial blood gas. That was the most commonly omitted test in the opinion of the case viewers. They also thought that a serum troponin would have improved the assessment of 8% of patients, with a corresponding figure for point-of-care echocardiography of 2.3% and brain natriuretic peptide 3.1%.
We also recommended that each patient who is discharged from hospital with the diagnosis of acute pulmonary embolism have a follow-up plan along with patient information leaflet and a copy of the discharge letter before they leave hospital. A discharge letter should include the possible or likely cause of pulmonary embolism, an estimate of whether it was a provoked or unprovoked case of pulmonary embolism, any details about a follow-up appointment or further investigations required. It should also include details of anticoagulation treatment started and the expected duration of that treatment. Outpatient follow-up was not routinely arranged following a pulmonary embolism diagnosis in about 17%. Where routine outpatient follow-up was arranged, it included a decision on the duration of treatment in about 93% and a possible estimate of whether this was provoked or unprovoked in about 90%. Treating clinicians were unable to determine if patients were given verbal or written information about their pulmonary embolism in 56% cases. And finally, case reviewers were of the opinion that follow-up was inadequate in about 16% of patients because information provided to patients was not considered adequate.
%38% of patients had one or more delay in their care. Delayed recognition of pulmonary embolism as the cause of the presentation, along with failure of timely investigation and treatment delivery, were the most common delays. The case reviewer's judgment of the overall quality of care was that 40.9% had received good care. Opportunities to provide better care to patients with acute pulmonary embolism was identified in 48.9%, with 3.2% categorized as having less than satisfactory care. If you would like more detail on this report's findings and recommendations, the full report can be accessed and downloaded at www.ncpod.org.uk